Good morning, everyone. Today we will discuss about collagen vascular disease and connective tissue disease. Collagen vascular disease. First one is systemic lupus erythematosus. Next one is dermatomyositis. Third one is scleroderma, and last one is juvenile idiopathic arthritis. So we have four types in collagen vascular disease: systemic lupus erythematosus, dermatomyositis, scleroderma, and juvenile idiopathic arthritis. We will see about each and every one of these separately about the clinical features presentation. Collagen vascular disease or autoimmune disease. Now we have different types of collagen vascular disease and autoimmune diseases. Now this list is present. I will go through this list. First one is adult Still's disease. Second one is polymyalgia rheumatica, temporal arthritis, rheumatoid arthritis, rheumatoid fever, inflammatory bowel disease, Ritter's syndrome, systemic lupus erythematosus, vasculitis, polyarthritis nodosa, giant cell arthritis, Kawasaki disease, and Still's disease. These are the collagen vascular or autoimmune disorders we see in our day-to-day practice. Now, in this we have systemic lupus erythematosus, rheumatoid arthritis, progressive systemic sclerosis, polymyositis or dermatomyositis, and Sjogren's syndrome. And this side we have usual interstitial pneumonia, non-specific interstitial pneumonia, diffuse alveolar damage, and bronchiolitis obliterans, lymphocytic interstitial pneumonia, hemorrhage, and airway disease. You can see plus marked against each and every disease. In SLE, you can see usual interstitial pneumonia is present. In rheumatoid arthritis, also it is present. So in the first row, the pneumonia is present in all these connective tissue disorders. Next, in second row, you can see non-specific interstitial pneumonia. Again, you can see plus marks for all this interstitial pneumonia. You can see more in the progressive systemic sclerosis and polymyositis or dermatomyositis. Next, you can see diffuse alveolar damage. Third row, it is also present in the first four disorders. The last two, it is absent. Next, bronchiolitis obliterans. You can see in SLE, it is present. Rheumatoid arthritis, it is absent. Progressive systemic sclerosis and dermatomyositis, Sjogren's syndrome, it is present. And as you go down, you can see lymphocytic interstitial pneumonia. It is seen only in Sjogren's syndrome, and hemorrhage you can see only in SLE, and airway disease is seen in rheumatoid arthritis and Sjogren's syndrome. So this is how you can classify based on their pulmonary disease. So based on the pulmonary disease, we can classify systemic lupus erythematosus, rheumatoid arthritis, progressive systemic sclerosis, polymyositis or dermatomyositis, Sjogren's syndrome. So all these things will be classified according to your pulmonary disease presentation. Based on the presentation, you can decide where it fits into in all these disorders. Next is histological pattern and histopathological findings common radiographic findings, distribution of CT and usual CT findings. So the first one is histopathological finding, and the last thing is radiological findings. So in interstitial pneumonia, you can see in histopathological findings, architectural destruction, fibrosis with honeycombing, fibroblastic foci, alternating areas of normal lung tissues and inflammation, fibrosis and honeycombing. And in radiological findings, you can see reticular abnormalities with volume loss, mostly in the basal region. Distribution of the CT, peripheral, subpleural and basal regions. And usual CT findings, irregular, linear areas are seen, honeycombing, bronchiectasis, architectural distortion, focal ground glass attenuation. These are the findings you see in interstitial pneumonia. Next one, non-specific interstitial pneumonia. There is varying proportions of interstitial inflammation and fibrosis divided into cellular and fibrosing patterns, patchy with intervening normal lung tissues and temporally uniform arrangement. Here radiological finding, you see ground glass appearance. The same way you are given histological findings and radiological findings for bronchiolitis obliterans. Next one is diffuse alveolar damage, lymphocytic interstitial pneumonia. For all these things, now it has given histopathological findings and radiological findings. Based on this, you can classify the type of the disorder. Now we go into rheumatic fever. So how rheumatic fever will present? Rheumatic fever may be characterized by an acute migratory arthralgia, usually of larger joints, mostly ankles, knee, hip, wrist, elbow and shoulders. The involved joints may be swollen, tender, red hot and painful. The joint is usually symptomatic for 2 or 3 days, and then the migratory arthritis move on to involve other joints. The inflammatory arthropathy usually resolves without any residue. Similar arthropathy may occur with leukemia, inflammatory bowel disease, and gonorrheal and meningococcal infections. So in rheumatic fever, there is migratory arthralgia. They mostly involve the larger joints. Common joints are ankle, knee, hip, wrist, elbow and shoulders. The involved joints are swollen, tender and red color, and you can see it hot and painful. When you feel the joint, it is hot and tenderness is present, and on movement it is very painful, and the joint is swollen also. And this joint is usually symptomatic for 2 or 3 days, and then the migratory arthritis will slowly move to other joints, leaving the initially affected joints. The inflammatory arthropathy is usually resolved without any residue. Similar arthropathy may occur with leukemia, inflammatory bowel disease, gonorrheal and meningococcal infections also. So you should be able to differentiate between all these conditions like leukemia, inflammatory bowel disease, gonorrhea and meningococcal infections. Next one is another important topic, systemic lupus erythematosus. It is characterized by migratory transient joint involvement with arthralgia, pain on motion, redness, swelling, and stiffness. The hands, wrist, knee are most commonly affected. The manifestations may simulate those of rheumatic fever or early rheumatoid arthritis. So SLE also presents with migratory transient joint involvement with arthralgia, pain on motion, redness, swelling, and stiffness. The hands, wrists, and knees are most commonly affected. Manifestations may simulate those of rheumatic fever or early rheumatoid arthritis. Next is serum sickness. So in serum sickness, it is characterized by joint redness, swelling, pain, stiffness, and considerable effusion is present. Urticaria may also be present. Skin rashes may be present. A serum sickness-like syndrome may be caused by hypersensitivity to penicillin, cefaclor, and other drugs. So in serum sickness, there is redness of the joint, swelling of the joint, pain, stiffness, and considerable effusion. Urticaria may also be present. A serum sickness-like syndrome may be caused by hypersensitivity to penicillin, cefaclor, and other drugs. Next topic is juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis has three chief modes of onset. First one is systemic onset. In systemic onset, they have high spiking fever and rashes, evanescent rash, abdomen pain, hepatosplenomegaly, and possibly marked generalized lymphadenopathy with concurrent or later appearance of arthritis. So in case of systemic onset, there is always fever along with rash, abdomen pain, hepatosplenomegaly, generalized lymphadenopathy, and arthritis. The macrophage syndrome may complicate systemic juvenile arthritis. Findings include again fever, lymphadenopathy, hepatosplenomegaly, anemia, leukopenia, thrombocytopenia, elevated liver enzymes, hypofibrinogenemia, prolonged prothrombin time, and easy bleeding. Bone marrow examination demonstrate hematophagocytic lymphohistiocytosis. So on bone marrow examination, you can demonstrate hematophagocytic lymphohistiocytosis. Polyarticular, that is 5 or more joints are involved. Rheumatoid negative form, which primarily affects females, has no systemic effect and carries a good prognosis. So any patient with no systemic effect carries a good prognosis. So in polyarticular, 5 or more joints should be involved. So you should ask history about involvements of each and every joint, and finally you have to conclude how many joints are affected. So 5 or more joints should be affected in polyarticular juvenile rheumatoid arthritis. Patients with rheumatoid factor positive polyarticular onset, which usually occurs after 8 years of age, experience severe arthritis, rheumatoid nodules, and vasculitis. So patients with RA factor positive polyarticular onset occurring after 8 years of age have severe arthritis and rheumatoid nodules with vasculitis. Next is quasi-articular onset. Here you have two types, type 1 and type 2. Type 1 has its onset in early childhood, especially in girls. Anti-nuclear antibodies are present. If only a few joints are affected, the outlook is good. So, depending on the joint involvement, the outcome also varies. If only few joints are involved, the outcome is good. In some patients, multiple joints become symptomatic over the years. Children with early childhood onset of quasi-articular arthritis have up to a 30% chance of developing iridocyclitis, whether or not the rheumatoid process is active. So, in some patients, multiple joints become symptomatic over the years. As time progresses, more and more joints are getting involved. So, children with early childhood onset of quasi-articular arthritis have up to a 30% chance of developing iridocyclitis, whether or not the rheumatoid process is active. So, a slit lamp examination should be performed 4 times a year. You have to examine the eyes with a slit lamps to rule out iridocyclitis. So, how many times you will do? 4 times per year. Next is juvenile. Same juvenile rheumatoid arthritis type 2 or school age onset, affects the hips, knee joints, ankles, and it is predominantly in boys. Involvement of sacroiliac joints and the lumbar and thoracic vertebrae occurs along with pain in the lower back, hips, or thighs. There is intermittent inflammation of tendon and ligament insertion sites. A family history of ankylosing spondylitis may be obtained. The anti-nuclear antibody and rheumatoid factor test results are negative. Enthesitis occurs in spondyloarthropathies and occasionally in other rheumatoid diseases and is more frequent in heel and knee. So, in type 2 or school age onset, the joints affected are hip joint, knee joint, and ankle joint. This is predominantly seen in boys. There is involvement of sacroiliac joints and lumbar and thoracic vertebrae occurs along with pain in the lower back, hip, or thighs. Intermittent inflammation of tendon and ligament insertion sites may occur. A family history of ankylosing spondylitis may be obtained. The anti-nuclear antibody and rheumatoid factor test results are negative. Patient may present with enthesitis. Onset of the disease is frequently insidious with the gradual onset of pain and swelling of knee, ankle, and limbs, and there is limping. Systemic symptoms such as easy fatigability, morning stiffness, anorexia, and poor growth. Clinical manifestation may be confined to the joints. Low grade or spiking fever may be the earliest symptom. The rheumatoid arthritis is to be considered as a diagnostic possibility in children with spiking fever or undetermined origin. Fever accompanied by chills may be over 105 degrees Fahrenheit or 40.5 degrees Celsius. The onset of joint involvement is acute with transient migratory polyarthritis and fever. So there is the onset is frequently insidious with the gradual onset of pain and swelling of knee, ankle, and there is a limping. Systemic symptoms are such as fatigability, morning stiffness, anorexia, and poor growth is present. Clinical manifestations may be confined to the joints only. Low grade or spiking fever may be the earliest symptom. So rheumatoid arthritis is to be considered as a diagnostic possibility in any child with spiking fever of undetermined origin. So the fever may go up to 105 degrees. The onset of joint involvement is acute with the transient migratory polyarthritis and fever. Later on, there may be muscle atrophy, especially around the joints, may be severe. Combination of joint effusion and muscle atrophy causes spinal shaped fusiform swelling, often evident in proximal and distal interphalangeal joints. So, the combination of joint effusion and muscle atrophy causes spinal shaped fusiform swelling, often evident in proximal and distal interphalangeal joints. The overlying skin may be red, shiny, smooth, and atrophic. The skin may be red, shiny, smooth, and atrophic. Other manifestations: a transient non-pruritic erythematous or salmon pink macular or maculopapular skin rash, chiefly on the trunk, face, neck, and inner aspect of the extremities are present. Few experience hepatomegaly and splenomegaly. So there is muscular atrophy around the joints. There is joint effusion around the and muscle atrophy, which gives together a fusiform appearance around the joints. The skin may be red, shiny, smooth, and atrophic. Other manifestations: a transient non-pruritic erythematous or salmon pink maculopapular skin rash, chiefly on the trunk, face, neck, and inner aspect of the extremities can be seen. Few experience hepatomegaly and splenomegaly. Next, we go to dermatomyositis and mixed connective tissue disorder. In dermatomyositis, patient may have joint involvement similar to that of rheumatoid arthritis. Next one is mixed connective tissue disorder is characterized by polyarthritis, Raynauds phenomenon, lupus-like rashes, sausage-shaped digits, pulmonary dysfunction. Sjogren's syndrome may accompany with recurrent salivary gland enlargement and dryness of the eyes and mouth. Last, scleroderma may be accompanied by arthritis. So in dermatomyositis, patients may have joint involvement similar to that of rheumatoid arthritis. In mixed connective tissue disorder, it characterized by polyarthritis, Raynauds phenomenon, lupus-like rashes, sausage-shaped digits, pulmonary dysfunction. Sjogren's syndrome may accompany with recurrent salivary gland enlargement and dryness of the eyes and mouth. Scleroderma may be accompanied by arthritis. Next, we go to SLE. It involves the butterfly area of face. So over the face, over the cheeks, and across the nose with well circumscribed maculopapular, violaceous or reddish brown patches ranging from 1/4 to half inch in diameter. So there is a butterfly rash over the face. The V-neck area of the chest and exposed area of the arms may also be affected. Thin whitish scales may adhere to the lesion. Erythema, edema and capillary telangiectasis may occur over the involved areas. The butterfly rash may be a manifestation of other connective tissue disorder, including dermatomyositis. So it is seen both in SLE and dermatomyositis, which one butterfly rashes. Lesions may also appear around the nails and on the palms and exposed skin. Bulla may occur if inflammatory changes are severe. Some lesions recede rapidly without any residua. So in SLE, there is butterfly rash over the face, the V-neck area of the chest and the exposed area of the arms may also be affected. There is thin whitish scales adhere to the lesions. Erythema, edema and capillary telangiectasis may occur over the involved areas. The butterfly rash may be a manifestation of other connective tissue disorders also, like dermatomyositis. Lesions may also appear around the nails and on the palms and exposed skin. The bulla may occur if inflammatory changes are severe. Some lesions recede rapidly without any residua. Persistent lesions lead to local atrophy and pigmentation of the skin. Photosensitivity or Raynauds phenomenon may be reported. Few cases with systematic involvement may not have skin lesions. Discoid lupus erythematosus, that is elevated indurated lesions on the face and exposed areas, often followed by scarring, but it is not accompanied by systematic manifestation. So systemic manifestations are not there, but a skin involvement is there. Neonatal lupus erythematosus, oval shaped, slightly atrophic, macules, papules, or plaques with peripheral scaling, predominantly on head and neck, is seen. What are the associated findings in SLE? So in SLE, we have associated findings like heart block, thrombocytopenia, anemia, and leukopenia. Rheumatoid arthritis often develop blotchy erythematous lesions or migratory reddish macular eruptions that may be pruritic. Cobner's phenomenon may be evoked by scratching the skin in these patients. Several minutes later, a maculopapule appear along the scratch mark. The skin manifestation associated with serum sickness include dermatographia, pruritus, and urticarial wheals. Occasionally, the lesion may be erythematous, morbilliform, scarlatiform, or purpuric. Angioedema may also occur. This is in rheumatoid arthritis. Dermatomyositis. Here we have erythema, morbilliform, purpuric, urticarial lesions, brawny indurations, dovey edema, dermatitis on the upper eyelid, and periorbital edema. Gottran sign, that is erythematous, scaling, dermatitis, hypopigmented papules, telangiectasia over the knee, elbow, knuckles, interphalangeal joints. The malar prominences is virtually pathognomonic. Generalized edema may occur in some children. This is Gottran's sign. As the disease progresses, the tight, glossy, and bound skin gives an indurated, thickened, and leathery feel. The skin breaks down easily, and atrophy may occur with subcutaneous calcification. Gritty calcium deposits may occasionally extrude through the skin. Joint contractures may develop over the time. Dermatomyositis-like syndrome may occur with X-linked A-gamma globulinemia. So as the disease progresses, the tight, glossy, and bound skin gives an indurated, thickened, and leathery feel. The skin breaks down easily, and atrophy may occur with subcutaneous calcifications. Gritty calcium deposits may occasionally extrude through the skin. Joint contractures may develop over time. Dermatomyositis-like syndrome may occur with X-linked A-gamma globulinemia. So here one column is disease, second one is ocular manifestations, and third one is percent of patients with ocular symptoms. First one is rheumatoid arthritis. In case of rheumatoid arthritis, patients will have keratoconjunctivitis, scleritis, episcleritis, and ulcerative and necrotizing keratitis. So keratoconjunctivitis is 25 to 30%. All others are 5 to 10% each. In systemic lupus erythematosus, patient develops keratoconjunctivitis. It is 15 to 20%. Scleritis, episcleritis, keratitis, and retinal vasculitis, they are around 1 to 2% and 2 to 3%. Retinal vasculitis is 2 to 3% in well-controlled patients, 28% in active or aggressive disease. Next we go to Sjogren syndrome, ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. So in Sjogren syndrome, there is keratoconjunctivitis, that is 100% present in Sjogren syndrome. Then ankylosing spondylitis, you have uveitis, that is 30 to 33%. In psoriatic arthritis, you have conjunctivitis 30 to 65%, uveitis 20%. In reactive arthritis, you have conjunctivitis and uveitis. Conjunctivitis is 30% to 65%, uveitis is 35 to 40%. So in this picture, you can see a keratoconjunctivitis sicca in a patient with primary Sjogren syndrome. So this flow chart, you can see approach to a patient with collagen vascular disorder. So symptoms of fever, joint pain, Raynauds phenomenon, and photosensitivity. So if these things are present, next you go to other symptoms and signs. So first thing you see malar rash, oral ulcerations, and discoid rash. So if these things are present, you have to think about systemic lupus erythematosus. Second one is sclerodactyly, purse string mouth, pinched nose, hide-bound skin is seen in systemic sclerosis. Third one is dryness of mouth and eyes, decreased tear secretion seen in Sjogren syndrome. Next one is diabetes mellitus. Here, proximal muscle weakness, periorbital heliotrope rashes, and Grattan's papules. So this is how you will differentiate between SLE, systemic sclerosis, Sjogren's, and diabetic mellitus. In diabetic mellitus, you have proximal muscle weakness. Next, in lupus erythematosus. In lupus erythematosus, on the left side you can see photosensitive facial lesions, and on the other side annular psoriasiform plaques. So in photosensitive facial lesions, there is prominent centrofacial telangiectasia, pustules, nasolabial folds are involved. If these things are present, it has been diagnosed as rosacea. And if these things are absent, non-scarring malar rash or butterfly rash. In case of butterfly rash, go to acute cutaneous lupus erythematosus. The same way you have hardening of skin, knuckle involvement. This goes to diabetic mellitus. The last thing on the right side, you can see granuloma annulare, tinea, psoriasis, scarring, alopecia with trophic plaques. So, annular psoriasiform plaques, if you see in a triangular truncal pattern, dorsal arms are involved. So, if this is present, along with the scarring, alopecia, and atrophic plaques, then it is discoid lupus erythematosus. So, in case of annular plaques with lateral facial predominance, you have to do biopsy confirmation. Then, what are the investigations to rule out drug-induced SLE? Medical history, examination, CBC, CRP, RFT, renal function test, liver function test, ANA, anti-nuclear antibodies, and DS, DNA, double standard DNA, C3 and C4. So if it meets all the SLE criteria, we will diagnose it as SLE. If SLE criteria are not met, then treat it as CLE. That is cutaneous lupus erythematosus. This picture you can see a case of systemic lupus erythematosus SLE showing a periangle skin lesions and pigmentary changes. Other changes seen are longitudinal ridging, hyperkeratotic cuticle, and discoloration of the nails. This patient you can see with the discoid rashes. Ladies, you can see rashes over the chest wall and on the hands. This is Raynauds phenomenon. So because of severe vasculitis, there is no blood supply to the peripheries. You can see the involvement of the knuckles. You can see the upper eyelids. So differentiation between serum sickness and viral exanthematous illness. So onset, clinical presentations, and investigations. So how will you differentiate between serum sickness and viral exanthema? So in serum sickness, onset is commonly 1 to 2 weeks, rarely 1 month, resolves within a few weeks of drug cessation. So once you stop the drugs, the serum sickness also will stop. After that, clinical presentation, it is a pruritic urticarial rash from the lower trunk spreading to the back, upper trunk and extremities. Sparing of mucous membranes, where in serum sickness. Rapid resolution of rash, high grade temperatures, lymphadenopathy, myalgia and arthralgia is seen. So investigations, you can do reduced C3 and elevated CRP and ESR. Viral exanthematous illness, the onset is variable depending on the exposure to virus. Here there is mucous membrane involvement can cause urticarial rashes, which are viral infections, low grade temperature and arthralgia. And in investigations, reduced C3 and C4, positive serology and viral polymerase chain reaction. This can be done to confirm the presence of the virus and to know the type of the virus, either serological test or viral polymerase chain reaction, PCR. You can see a child with the rashes. Thank you.